Assalamu alaikum wa rahmatullahi wa barakatuh. Shukran for everyone for staying for the graveyard slot. Inshallah, we hope it will be worthwhile. So the topic sounds more complicated than it is. So just to give you some context, this is a PhD protocol I'm presenting, which is a build-on from my master's research that I will be going through as well. When we're looking at the framework and strategy for disability and rehabilitation, it's a mouthful, but in short, I'll refer to it as the FSDR. For those who aren't familiar, it's the closest document or policy we have to ensure disability rights in South Africa. We do not have any policy or anything within the legislature to protect the rights of persons with disability. Now, I know sitting here, you're mostly medical doctors. There are a few, I won't call it allied rehabilitation therapists, I'll call it rehabilitation therapists sitting here as well, who may be more familiar with the document. But how is this relevant to you as a medical practitioner? It is relevant. It's either that disability will affect somebody you know, somebody within your family, or generally your patient base. And within your patients, rehabilitation has the potential to firstly improve quality of life and decrease the burden that is placed on an already strained healthcare system. So for those in public sector, you know we cannot cope with the numbers. For those we're looking at spinal surgery, Dr. Islam just spoke about the prolonged disability that comes with spinal surgery, even in the case when you do your surgeries, apart from the fact those patients who never make it to the list, that resultant disability, and particularly with COVID, we have seen so much of secondary complications that in the next 5 years, we'll be looking at a different spectrum of disability completely. And that's why policy is so relevant, that we all understand how the policy is going to translate into practice for all of us. I just want to get the pointer. So why do we actually have to look at something like this? The prevalence of disability we know is increasing, and I've explained with COVID and the pandemic that just passed, the prevalence is increasing continuously, and we do not know what we'll be looking at within the next 2 years. For a lot of the medical doctors, you've seen a lot of cardiac complications. From a neuromusculoskeletal point of view, we've seen a lot of complications as well. And going forward, this is going to lead to disability if we do not intervene. A way to try and actualize the rights of persons with disability is policy. It's a tool that we can use, but we do not use it enough. We do not mobilize resources towards it. And the issue stems from we do not have enough policy analysts to actually show us the data on where are we with our policy implementation. And this is a policy talking to disability and rehabilitation particularly, but we need to factor in the power that policy has when it comes to advocating for more resources, etc. Speaking on that point, we know that we have some of the best policies. We have one of the best constitutions in this country. We know we fall short on implementation. But we as medical practitioners do not delve deeper and deep enough into our medical policies to see how much of what we say we do is actually done. And that's what our study aimed to do. To give you a little bit more context, this policy was developed back in 2015, and the reason it was developed was the United Nations Convention on the Right for Persons with Disability was signed by South Africa in 2006. We became a signatory. That mandated us to have a policy in place to protect the rights for persons with disability. Up until now, we do not have a policy. However, this is the closest document we have to that, which is the FSDR, and that's open access online as well. So the framework and strategy for disability and rehab aimed to outline rehabilitation service provision, and this spanned from a primary healthcare level all the way through to our specialized hospitals. It focused on rural service provision all the way through to our urban areas, and not only did it focus on physiotherapists, OTs, speech therapists, it went through to orthotics and doctors within the rehabilitation field. So to give you a bit of context into why the PhD is now what it is for my master's study, we had done just a brief policy analysis of the document itself. And we used the Walton-Gilson framework for policy analysis. So the benefit of having used a framework like this is that it allowed us to look at the policy holistically. Often when we look at a policy, we say, what is in it? We look at the content, and that's as far as we go. This framework allowed us to explore the actors, meaning who were the stakeholders involved, what were their role, and how did that translate into the content that the policy actually came out with in the end. We also looked at the processes that the policy followed and the context within the policy or within which the policy was developed. So as I mentioned before, we spoke about the UNCRPD, which placed international pressure on our country, which is why we eventually got to where we did. So this was from the master study that preempted this study. We did a document review, and we triangulated the data with a document review and semi-structured interviews with 12 participants. So just looking at a brief demographic overview, our participants ranged from professional bodies, individuals or rehabilitation managers in the public sector, as well as private sector, and more importantly is this research was commissioned by the National Department of Health and the Gauteng Department of Health. And this is something important that I'd like to bring to the forefront, that research has changed completely in the last 10 years, that research needs to be impactful. We are no longer at the point where we want to publish 50 publications and get promotions. We need to be looking at research that translates into practice and that collaborates with the societies in which we collect our data. And so we decided to collaborate with the National Department of Health because this was a mandate of theirs that the policy had to be analyzed, but nobody had the resources to actually do that, which is why we came in. So the results of the initial study was that in terms of the actors, there was a broad range of role players. So this included academia, professional bodies, so OTASA, numerous professional organizations. However, there was the exclusion of health economists. So a lot of our policies are developed with medical practitioners because we have the skill and the insight, but we do not bring in other sectors, and that's where we fall short. So within your clinical practices, again, it's something to factor in, that when we bring or develop even protocols within an orthopedic department, are we being multidisciplinary? And more recently, the approach is interdisciplinary. Are we including and having collaboration between other sectors? So, for example, in this case, the lack of health economists caused a perfectly good policy to fall short on implementation because of the lack of financial resource allocation. The context, we spoke about the global legislation that put us under pressure, and then situational and structural factors as well that mandated us and pushed and preempted for this policy to be developed. However, the actual content of the policy lacked alignment to access to healthcare, which is what it aimed for in the first place. And this lack of alignment resulted in a decreased distributional impact. So you're hearing a lot of information, but put this into context. 5 years worth of this policy was developed, all the effort and resources to mobilize a task team to get the policy developed, only to get a minimal distributional impact. That's something to be thinking, are we being smart with our use of resources, and how can we optimize it going forward, especially using policy as a tool for advocacy? The processes itself were broken into development, implementation, and then monitoring and evaluation. The development process, upon further investigation and through the semi-structured interviews, we found out that the Minister of Health appointed a task team. The task team then mobilized contacts that they had to come on board and develop the policy. Now, the issue with having such an approach is a top-down approach to policy development causes a lack of end-user engagement. So the people the policy was developed for were not necessarily included in the development of it. So how did we expect a difference to be made at ground level? So this was an overview of the results. I've spoken much to it, so I'll just go through it. The actors, if you look at development, implementation, and monitoring and evaluation, the list gets shorter and shorter and shorter of who is actually involved. And when we get to the end, no monitoring and evaluation has been done of the policy, no framework has been developed to actually evaluate the policy, and the National Department of Health is now sitting with a policy that has expired and now they need to monitor and evaluate. The issue with this is monitoring and evaluation is a process. It's not something that happens at the end of implementation. So this should have started at the beginning in 2015, which is where it's one of the flaws of the implementation process, but it's also something for us to take forward with future policy as well. The processes I've spoken to as well, and the content itself was fairly accurate. The content spoke to access to healthcare. It was based on a CBR philosophy, so the rehabilitation professionals will understand that community-based rehabilitation is a strategy, when used correctly, that can really be impactful. And it also covered a spectrum of care. So as I mentioned before, it ranged from not just focus on physical recovery from disability, but the mental health components as well. And then this is just a brief overview of the processes as well. So coming to the PhD that we're discussing today, our study aims to develop a framework for implementation science. So we want to develop a framework based on recommendations from the stakeholders on implementation for future disability policy. This policy was developed from 2015 to 2020. It was then extended until 2022 because of the COVID-19 pandemic. So we're currently sitting with a policy that is about to be revised at a national level. And if we do not intervene now, we're going to reinvent the wheel. Issues that we picked up will not be addressed, and it's going to be another 5-year cycle with minimal distributional impact. So these were the objectives. We do not need to go through all of them, but it's just to give you a context of how much needs to be done to develop the actual framework itself. 6 objectives: to be able to draw out enough information that we can have an informed framework that can actually be applied not just to this policy, but disability and rehabilitation policy in general. And it should be across contexts that it can be applied as well. So the problem statement, why did we actually have to do the research? I think the previous example of the master study gives a lot of context into, we know the prevalence of disability is increasing. We know we do not have the actualization of the rights for persons with disability. We know that policy is a tool to achieve this, but we have policies that have not been evaluated thoroughly, and we cannot be developing new policies without fixing issues from the previous ones. Again, through this analysis and through a proper development of the framework, we can have actual understanding or proper understanding of the gaps that were identified through the implementation process. And then how do we provide recommendations that are actually going to change? When we go to the National Department of Health, and we've done this a few times, when you go to them appealing or advocating for a patient, they ask you for the data, they ask you for the stats, and we never have that to show. And so this is something solidified to present to mobilize resource allocation. This can also help with informing rehabilitation service provision going forward, both in a rural and urban setting. And this is something really important to think of with national health insurance. I know some people are skeptical of it, but universal health coverage is a consideration and something we should be thinking about just at the back of our minds. So this was the study conceptual framework. We were going to, how do we actually utilize methodologies to achieve the outcome that we intend? So we're going to use 3 different methods. The initial part is a document review, and this is a different document review. We've already analyzed the policy, and we're going to use that to solidify our data. But what we're going to do now is that the National Department of Health rolled out their first phase of M&E this year, started in January this year. What they've done is they've sent out a paper-based evaluation through all 9 provinces. We have spoken and collaborated with the National Department of Health to do a document review of the paper-based evaluation from each provincial rehabilitation manager. To compound this information, we're then going to conduct semi-structured interviews, because this is a purely qualitative study, and compound that further with focus group discussions. So the semi-structured interviews are going to be with stakeholders all the way from, and we want to avoid a top-down approach, but we want to include end users, so disability persons, organizations themselves. all the way up to a management level at National Department of Health, and then your provincial rehabilitation managers as well. We also want to include civil society, academia, and professional organizations. And then for our focus group discussion is then, how do we take the recommendations from the document review in phase 1, the recommendations from the semi-structured interviews in phase 2, combine all of that information to develop an informed framework. So the first few focus group discussions will be held to get a skeleton structure. We'll review the framework, refine it, and take it back to the experts, take it back to the end users to see what's falling short in the framework, and then finally develop our framework. So for those involved in implementation sciences research, you might be familiar with the Proctor Model, which is a very common model that is used to evaluate how good was the implementation. It's enough for us to say this was implemented, but to what extent? We need to be able to evaluate that. Bearing in mind, this is just a PhD study, so the size of the study has to also be contained to some degree. So we're looking at the perceptions of the implementation outcomes. And we have selected a certain number of these that are applicable to our study context. Because of the scope of the study, we won't be able to cover all, and we do hope that we can expand on that going forward. So this was just the operational definitions of the 4 components that we did select, which was acceptability, appropriateness, feasibility, and sustainability. When we submitted this protocol to ethics at WITS, the first question was, how do we actually quantify this information? This is a qualitative study. We're looking at the perceptions of the implementation outcomes. The next step is that when we do M&E, that we quantify all of this information. So our methodology, it's a qualitative study. We're looking at the Johannesburg Metropolitan District with all the sub-districts, and should we get sufficient funding and resource mobilization, we're going to expand beyond the 1 district and do all 4 other districts as well. The source of participants are rehabilitation managers, professionals, clinicians. We also have National Department of Health on board, and then the Gauteng Department of Health, and then the national professional bodies as well. We're using a purposive and snowball sampling approach. So purposively, we're selecting our main participants who are stakeholders involved in the implementation process, and from there we'll be snowball sampling depending on recommendations made. The participant, again, this is just giving us a brief overview of the steps we're going to follow, and inshallah, the outcome of this PhD is a framework development. So outcome measures and instrumentation, we do not actually need to use a lot of resources towards the data collection process. We're going to use a semi-structured interview guide, focused discussion interview guide, and then the document review guide as well, which has been developed already. So we're doing deductive thematic analysis of the document review. This was the framework that is currently in the policy. There are objectives and indicators that correspond to each one. So instead of reinventing the wheel, we'll be deductively analyzing the content of the actual paper-based evaluations using the framework that came from the policy. Then our semi-structured interviews, if you look through how do we actually get the information we need from our participants. And then our focus group discussion. How do we engage stakeholders in the way that we're going to get the right information? Often with qualitative research, we ask the wrong questions and we don't probe enough. So this is our attempt at getting the right information. And then trustworthiness strategies. For anybody in qualitative research, we're always looking at particularly reflexivity and positionality. So standard is your credibility, transferability, but these are the 2 that have come up within the last few years in qualitative research. How reflexive is the principal investigator? And looking at our case, I've been invested in this policy from the time of my master's. I've been working as a rehabilitation as a physiotherapist for a good few years, both in the public sector and private sector. How does my position, firstly, as a rehabilitation practitioner, secondly, as a researcher, and now as an academic at the university where we train students, How does my position and experience influence the way I ask the questions to our interview participants? And how does it influence the way that I perceive their responses? And this is something that as researchers we need to be cognizant of as well. Implications. Clinically, we need to be informed. How do we influence disability practice? And then also with our policymakers, we need to ensure that they can utilize this to make sure the right issues reach the agenda in the end. And I'm drawing to a close now. We had all our ethical considerations and permissions, and Jazakallah khair.